and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The P&A is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The P&A is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Today's webinars, The Essentials, the Diagnosis and Treatment of Hypopituitarism, will be presented by Dr. John D. Carmichael. Dr. Carmichael is the co-director of the USC Pituitary Center and associate professor of clinical medicine at the Keck School of Medicine at the University of Southern California. After earning a degree in biomedical ethics at Brown University, Dr. Carmichael graduated from the Medical College of Virginia in Richmond. He then completed internship and residency at Virginia Mason Medical Center in Seattle, Washington. He received his endocrinology fellowship training at NYU, where he received a research fellowship grant to conduct clinical trials devoted to growth hormone deficiency and acromegaly after his clinical fellowship. In 2006, he moved to Los Angeles to join the Pituitary Center at Cedars-Sinai Medical Center, where he cared for patients with pituitary disease, devised and conducted clinical trials, and taught medical students, residents, and endocrinology fellows. In 2014, he joined the faculty at the University of Southern California. He has authored several journal articles devoted to clinical pituitary medicine, book chapters covering hypopituitarism and hypothalamic disease, and sits in the editorial boards for the Pituitary and Endocrine, Diabetes, and Metabolism Case Reports. Thank you, Dr. Carmichael. We appreciate your involvement in our webinar program. There will be a brief delay as we change presenters. You should see on your end, Dr. Carmichael, a thing asking you to accept.
I see it now.
Okay, it's all yours.
All right. Well, thank you, Tammy, for that introduction, and thank you for the invitation, and thank you to the rest of the Pituitary Network Association for the invitation to speak about hypopituitarism. The title of my talk is The Essentials, the Diagnosis and Treatment of Hypopituitarism, and what we'll find through the course of the presentation here is that I have several essential clinical pearls that are scattered throughout the lecture. These are sort of big take-home messages for patients and for people who treat pituitary disease, so that we can have a better understanding of what some of the most important aspects of the treatment and diagnosis of hypopituitarism are. So, okay, we'll start with just a review of anterior pituitary function, and recall that the pituitary is the so-called master gland, and that's because it has several pituitary hormones that then go out in circulation to control other hormonal secretion in other glands of the body. So we have, for example, ACTH, TSH, LH and FSH, the gonadotropins and growth hormone that are secreted by the anterior pituitary. These go out to their target glands and then in concert with other feedback mechanisms release cortisol, thyroxine, testosterone and estradiol, and IGF-1. One of the important principles of endocrinology is that of negative feedback, and each of these hormones, except for prolactin, participate in a negative feedback loop that goes back to the anterior pituitary and the hypothalamus to help regulate the amount of hormones that are synthesized and secreted by the anterior pituitary. I also have here on the slide the posterior pituitary, which we'll briefly discuss through the lecture today. Posterior pituitary is regulated differently. The hormones that are involved in thirst and urination are synthesized in the hypothalamus and transported down to the pituitary, to the posterior pituitary, and these are regulated by different mechanisms involving blood pressure and the sodium and water content in our body. So some basic terminology. Hypopituitarism refers to essentially any pituitary failure, any of those hormones that I mentioned before. If one of them is affected, then that is, by definition, hypopituitarism. It usually is referring to the anterior pituitary hormones, ACTH, TSH, LH, FSH, and GH. But these can also, it can also include the posterior pituitary. And as I mentioned, the deficiency in those hormones, which are regulated differently, can cause diabetes insipidus, which is a lack of vasopressin, or also called antidiuretic hormone. Panhypopituitarism specifically talks about the failure of all pituitary hormones. And so each and every one of these hormones is affected when we talk about a patient with panhypopituitarism. How common is it? Well, pituitary failure is estimated to be about 4.2 persons per 100,000 population, and the prevalence, so the number of people out there at any one given time, is about 45 per 100,000. And these data come from national registries from Europe, and they have a very close eye on how many patients are being diagnosed and treated for hypopituitarism in their national health systems. But these numbers may be an underestimation, and one of the big players in that may be traumatic brain injury related hypopituitarism. In the last decade or so, we've discovered that there are pituitary deficiencies that are the result of traumatic brain injury. And if we look at the estimated incidence of traumatic brain injury in the United States alone, of 80 persons per 100,000, just a conservative estimation of the traumatic brain injury related to hypopituitarism alone may be about 10 to 20 cases per 100,000 per year. And so we may be underestimating the amount of hypopituitarism that we see here in the country. We'll talk briefly about traumatic brain injury at the close of the lecture today. It's a challenging topic and one that's filled with a little bit of controversy. So what are the causes of pituitary failure? I like to break these down into structural and functional causes, mostly because I think that there is a difference in the way that we treat them, there is a difference in the way that we expect any kind of recovery, and we'll talk a little bit about the differences between these. The most common structural cause is that of a neoplasm, which would be a pituitary adenoma, which by far is the most common cause of pituitary failure. Other pituitary masses or cellular masses like craniopharyngioma and other cellular or paracellular masses like cysts can also cause pituitary failure as well. And then of course the treatment of those things can also lead to pituitary failure as well, surgery, radiotherapy, or radiosurgery. There are also more rare forms, things that happen because of infiltration of the gland, things like sarcoidosis, hypophysitis, and there are genetic causes that happen since birth. And then going over to the other side of the slide here, functional causes. These things tend to come from endogenous or exogenous hormonal excess. And so if you're taking any one type of hormone, that can suppress that feedback loop that we talked about in the first slide, and can lead to then suppression of the target hormones. And so we have essentially a what might be a transient or can be in some cases long-lasting suppression of the gland, and therefore a pituitary failure. Systemic disease can also cause a functional hypopituitarism, and some of the causes of that might be things like obesity, anorexia, or chronic illness. And then of course the medications interfere with pituitary function as well. We're going to have a couple of cases to discuss during the lecture, and we'll start with this one. This is David, of course not his real name, and he's a 17-year-old male who was in good health and came to attention because of progressive visual field loss. He complained of headaches, lethargy, and fatigue. And on direct questioning, when we talk about his history, he recalls the exact day that he began feeling fatigued. And this is a little peculiar. We don't often have that exact day nailed down to tie in some of the symptoms that we have, but he recalls this months ago, and since then has been feeling fatigued. His current complaints are of weight loss and anorexia, and he, going through his past history, at 17 he reports normal developmental milestones, denied any decrease in his libido, and he was sent to an ophthalmologist because of the visual complaints, who noted visual field cuts and optic nerve pallor. Because of this, some testing was performed, and he had an MRI done that showed a large stellar mass. As you can see here by the slide, we have a coronal view, and this coronal view shows a large stellar mass occupying the cella with suprasellar extension. Here's the optic chiasm up here, so there's compression of the optic chiasm and optic nerves here. And here we see the sagittal view. And what's interesting about this sagittal view is this vertical line here. Remember, the patients are lying down, and so this line is actually on the horizontal plane and indicates that there is a fluid level within this mass. When things settle out like that, you know that there is some cystic component to the patient's pituitary mass. He had a laboratory workup that consisted of assessment of his adrenal axis. He had a morning cortisol level that was nearly undetectable. He had a pair of thyroid hormones, the TSH and the total thyroxine, that indicated central hypothyroidism here with a low TSH and a low total thyroxine. He had assessment of his gonadal axis with a low free testosterone, a low total testosterone, very low when you consider the normal range being 250 to 1100. In a 17-year-old male, you would expect him to have a very robust testosterone level, and very low levels of LH and FSH. His prolactin was elevated at 178, not quite to the level with the size of the mass that you would think of immediately having a prolactinoma, but quite elevated, and his IGF-1 was on the lower side with a level of 163, actually below the lower limit of normal for his age range. He was treated initially prior to coming to see me with glucocorticoid and thyroid replacement because of the profound loss of those hormones and the need to acutely replace those. He was given bromocriptine for the treatment of the hyperprolactinemia. This is a medication that we use for all forms of hyperprolactinemia, and then sent to us. And in our evaluation, because of the cystic nature of the mass and because we weren't completely sure about whether or not this was a prolactinoma, we recommended transsenoidal surgical resection. He was found to have a hemorrhagic lesion filling the cella with lots of blood. A small amount of tumor was removed, and the normal pituitary was visualized at the time of surgery, an important aspect of preservation of pituitary function. And the pathology was consistent with a hemorrhagic prolactinoma. After his surgery, the replacement medications were weaned, and we anticipated a consultation with a pediatric endocrinologist because of the profound hypogonadism. I should mention that on his physical exam there was evidence that he had gone through somewhat of a pubertal arrest. He had incompletely gone through puberty, and there were some indications that he had not completely gone through his pubertal development. But in a short time after his surgery, he demonstrated full hormonal recovery, including normal testosterone, thyroxine, cortisol, and prolactin. And so that consultation with pediatric endocrinology to help take him through puberty with what I anticipated to be necessary was actually not needed at all. And in fact, his demeanor and his attitudes about his energy and his sexual drive completely changed in the short course after the surgery. When we talk about recovery of pituitary function after surgery, there can be a wide variation in effects. This was undoubtedly a very good outcome in terms of the pituitary recovery after his surgery. We know that pituitary function can recover almost immediately after pituitary surgery. In his case, is a good demonstration of that. Improvement of function has been known to be present in about 36 to 65% when we look at large surgical series. deterioration of function is actually a very low frequency event. So when patients come to us, it's very rare for us to have further damage to the pituitary. In many cases, large tumors have already caused a certain degree of hypopituitarism, and further deterioration is uncommon. In many cases, there's no change in pituitary function. So once the damage is done with a pituitary mass, surgery in many cases does not alter that. We always hope for pituitary function recovery, but in some cases we don't attain that goal. So this brings us to our first essential clinical pearl. And in his case, this was a prolactinoma, and it's notable that he had a very profound hypogonadism. What's interesting to know is that the hyperprolactinemia that comes from pituitary tumors or from normal pituitary function, when excessive, can feed back to the hypothalamus and cause a hypogonadism, and it interferes with the secretion of LH and FSH, interferes with menstrual periods, interferes with testosterone production, and that hyperprolactinemia, when treated, can result in recovery of the gonadal axis without treatment with sex steroids. So it's not absolutely necessary to treat a patient with hypogonadism due to hyperprolactinemia with estrogen or testosterone. In many cases, if the symptoms are not profound, you can wait and see if the testosterone and estrogen recover once you've treated the hyperprolactinemia. There is a typical pattern of hypopituitarism. In our first case, the patient had pan-hypopituitarism, but the pattern of pituitary damage is fairly typical. It usually begins with affecting the growth hormone, and then affecting the gonadotropins, and therefore then the menstrual periods or testosterone level. It then can affect the thyroid function, with, affecting the TSH and then ACTH, and very rarely does prolactin become involved with pituitary damage. When we look at patients who are followed prospectively after radiation, there's a slight difference in the drop-off of pituitary hormones, but as you can see, going out from the radiation therapy, growth hormone here tends to be the first affected. ACTH and LH and FSH here tend to be the second most common hormones or group of hormones affected, and then TSH tends to be the last affected by radiation. It's not clear why that is, but there does seem to be a difference between the typical pattern of mass effects versus radiation-induced effects of on the pituitary. Another thing to talk about here is the clinical manifestations of pituitary failure. And in an acute setting, there are very few symptoms that we pick up on with patients because of any hormonal loss. And that's because of, in many cases, the hormones that are in the body are have a long half-life, and we may not recognize any symptoms right away in the acute setting. Of the utmost importance, though, is that of ACTH deficiency in the acute setting, where patients may have profound adrenal insufficiency, they may have weakness, nausea, vomiting, and hypotension, and this may happen when patients have an infarction or apoplexy to their pituitary. More commonly, we see chronic symptoms, and if we can start here at the bottom of the table, the most common hormone being affected being growth hormone, we see problems with decreased muscle mass, central adiposity, decreased quality of life, and impairment in cognitive function. Now, these are all non-specific, so it's not automatic that we immediately think of growth hormone when we see patients who have this, and in fact there's a lot of overlap with the normal aging process and the loss of growth hormone. These symptoms are very similar. In men and women, when the gonadotropins are affected, we see fatigue in men, decreased libido, loss of facial and pubic hair, infertility. In women, amenorrhea, decreased libido, and infertility. With the thyroid function, when the TSH is affected, thyroid hormone takes a while to come down into the below normal range, and when that does happen, we then see fatigue, constipation, and bradycardia, some of the things that are very commonly seen in primary hypothyroidism. when the thyroid is affected. And then with ACTH, for chronic symptoms, we see fatigue, weight loss, and anorexia. So it's important to think about functional causes when we're evaluating patients with hormonal deficiencies, and that's because sometimes it can be misleading. I've seen several patients who it's been a little bit of a mystery why they have a deficiency of any one hormone. And so especially when some of the hormones are affected and others are intact, then it's a good idea to think about excessive endogenous or exogenous hormones, meaning hormones that are coming from the body or coming from an outside source. And so especially with ACTH, things like steroid withdrawal or any use of any kind of steroid, oral, topical, injection, inhaled, these can all cause suppression of the adrenal axis and then can result in adrenal insufficiency. Similarly with the thyroid axis, so when patients have prolonged hyperthyroidism, either from taking large amounts of thyroid hormone or when patients have excessive thyroid hormone production from their thyroid from, say, Graves' disease or some other autoimmune process. With testosterone or estrogens, very typically we'll see a functional hypogonadism when patients are using prolonged anabolic steroids. And so there's a long recovery period after use of testosterone or other anabolic steroids. In addition, as I mentioned before, functional hypogonadism can happen with changes in weight or with obesity. So excessive weight loss, very low-calorie diets, and exercise. We see this often in patients who are long-distance runners or gymnasts, and when there's sort of a caloric mismatch between the caloric expenditure and the amount of calories taken in. With growth hormone, it's well known that obesity, especially central or abdominal fat, plays a role in growth hormone suppression. And so even with all the testing that we have, growth hormone can be affected by these changes in fat and can cause a low growth hormone level. In addition, with children, when they have hypothyroidism or delayed puberty, that's also associated with a functional or short-term growth hormone deficiency. So our next essential clinical pearl, when being evaluated for hypopituitarism, if something doesn't make sense, consider the use of exogenous hormones. And this sometimes is something that even patients may not be aware of. Often patients are given injections at distant time from the actual visit, and these may include high doses of steroids that in many cases physicians don't recognize to be the culprit in adrenal insufficiency. So good to think of these things as you're being evaluated. So this brings us to diagnostic testing, and all diagnostic testing for pituitary disease requires the assessment of both the secretion and the integrity of the pituitary hormone, and this is especially important in thyroid function. We'll talk about that in just a moment. In many cases, we can use what's called basal testing, or a non-dynamic test for some of the pituitary hormones. But what's interesting about the pituitary is that we have a lot of dynamic tests that look at the pituitary secretion as well as the function of these hormones. And in many cases, dynamic testing may be required for the full assessment of pituitary function. There is a lot of variability in the assays that we use, and not all labs measure these hormones in the same methodology. In addition, over the last few decades, there have been several advances in assay technology, and so as we adapt to using newer assays, which are more sensitive and specific to these hormones, we still rely on these cutoff points that have been established in the past, sometimes using older assays. And so it's important to recognize that there are some differences in the way that we measure hormones today compared to what we've done in the past. In addition, there are many tests that were used in the past for pituitary assessment that are unavailable or not performed today. And so unfortunately, there are a lot of hypothalamic peptides, things like TRH, which is a thyrotropin hypothalamic thyrotropin stimulant, and this was used for assessment of pituitary function. It's no longer available in the United States. Similarly, growth hormone releasing hormone, or GHRH, was a component of a test for growth hormone deficiency, and that is no longer available in the U.S. as well. So we've had to adapt our testing because of the availability or lack of availability of these hormones. Let's go through some of the ways that we test these different axes. The pituitary, hypothalamic pituitary adrenal axis, or HPA axis. Again, this is assessment of the ACTH function and secretion. Both ACTH and cortisol, which is secreted by the adrenal gland, have a diurnal or pulsatile secretory pattern. And so usually people are making more cortisol in the morning, they're making less cortisol throughout the day, and to nearly undetectable levels at midnight. And so random measurements of ACTH and cortisol, because of the pulsatile nature of the secretion, are generally not helpful. But when we need to do it, and we need to do that fairly often, you should do it at as a basal or morning serum cortisol level. And if the level is above 18, adrenal insufficiency is essentially ruled out. A level below 3 is highly suggestive of adrenal insufficiency. And then anywhere in between, we have a degree of uncertainty. And if a patient does not have symptoms of adrenal insufficiency, being on the high side of that mid-range, maybe up to from 15 to 18, is usually acceptable. And but numbers between 3 and 18 in many cases require dynamic testing of the HPA axis to firmly establish whether or not a patient has adrenal insufficiency. The test that's most commonly used in the United States is the ACTH stimulation test. And this is useful for the diagnosis of primary adrenal insufficiency. That's when the adrenal gland is affected by some kind of malady, or a chronic adrenal insufficiency, and this can be chronic from a central cause, either pituitary or hypothalamic. When we use it like that as a secondary adrenal diagnosis of secondary adrenal insufficiency, we can only use it after the adrenals have atrophied. This happens after several weeks of having a lack of ACTH, because ACTH has both secretory properties and trophic properties, meaning that it maintains the growth of the gland. And so once the adrenals have atrophied because of a lack of ACTH, that test becomes much more reliable. There are two tests that have been developed. There's a standard test, which is 250 micrograms, and there's a 1 microgram stimulation test. And the 1 microgram was developed to address the poor sensitivity of the standard test, because both a 250 microgram dose and a 1 microgram dose are far more than our body normally secretes. But in looking at how these tests perform, the low dose and the high dose have performed similarly when analyzed by a meta-analysis. When you take all of the papers that have been published on this topic and compare how they perform, they seem to perform fairly similarly. Now, there's some disagreement in the literature about this point specifically, but suffice to say that there is some variability in both the results of the 250 and the 1 microgram test, and both can be used for the assessment of central adrenal insufficiency. But here we have our next clinical pearl, and that is that the ACTH stimulation test can give us falsely normal results when not enough time has passed for adrenal atrophy to take place. And so when we use these tests, the 250 or the 1 microgram test, immediately after a pituitary surgery or immediately after a pituitary apoplexy or infarct, then the tests may give us a normal result when in fact the patient may have adrenal insufficiency. So when in doubt, my recommendation is to replace the glucocorticoids and then perform that stimulation test after more time has passed. And you want to make sure that you're not giving excessive doses that would suppress the gland. For assessment of the thyroid axis, we can use, in this case, basal testing, but it is very important to use both the TSH and a measurement of thyroxine or T4. It is preferable to use a test of free thyroxine because changes in the binding proteins that carry thyroxine in our blood may alter the results of a thyroxine test. And it's important to get those pair of hormones because the serum TSH in patients with pituitary disease, when they have central thyroid insufficiency, can be normal in about 84%, can be elevated in a small number, and it's uncommon for the TSH to actually be in the low range. If you recall our case, the patient did have a low TSH and a low T4. That would be uncommon. The most common presentation is that of an inappropriately normal TSH in the setting of a low T4. What we know about the TSH molecule is that when it's secreted by the pituitary, it has a reduced bioactivity when that patient has a pituitary insult. If it's a pituitary tumor, if it's pituitary radiation, or after pituitary surgery, the TSH is not functioning in the same way, but it may be picked up by the lab when they test for the levels of TSH. Looking at T3 levels, the body would like to preserve the T3 level, and so there are mechanisms in place, enzymes that convert T4 to T3 that will try to maintain a normal level of T3. T3 is triiodothyronine. It is a breakdown product of thyroxine, and it is the more potent of the two and the most biologically available and active thyroid hormone that we have circulating in the body. But it generally is not helpful in determining whether or not a patient has hypothyroidism. We rely more on the thyroxine level, the T4 level. When we assess gonadal function, that of course varies depending on the gender and age of the patient in question. So adult males, we're going to be focusing on measuring testosterone, and testosterone is best measured between the hours of 7 to 9. That's when the normal ranges for testosterone for men have been established, and so we look at predominantly total testosterone. Measurements of free testosterone are sometimes unreliable in the lab, and our definitions of hypogonadism arise primarily from assessment of total thyroxine, or total testosterone. It's important to measure the pituitary counterparts, the LH and FSH, and this helps in your differential diagnosis. This helps make sure that what we're looking at is actually a central deficiency rather than a primary or testicular deficiency. Our normal results are usually we would like to have age-adjusted testosterone. We have these for patients who are going through puberty and below, and we have a broad normal range for adult males. And in the near future, hopefully we will have something that's more specific to the age of the patient that we're evaluating. But currently, most labs just give us one broad adult range for all male adults. In the setting of central gonadal dysfunction, the LH and FSH may be normal or low. It's not absolutely necessary to have low levels of LH and FSH to make the diagnosis. For assessment of women, it depends on the patient's menopausal status. If the patient is premenopausal, then a menstrual history is our best way of assessing that patient's gonadal axis. It's better than any testing that we can perform looking at estradiol levels in LH and FSH. And if the patient has a normal, regular menstrual history, then that implies that the gonadal function is intact and that there's no suggestion of any deficiency. For postmenopausal women, we look at levels of estradiol, LH, and FSH because we expect that once women have gone through menopause that the estradiol should be low, and the LH and FSH will, in a response to that low estradiol, rise to levels that are typically associated with postmenopausal status. If we don't see that, then that implies that there has been some pituitary damage to the gonadal axis. And this, by proxy, then implies that there may be pituitary damage to the other parts of the pituitary as well. When we test patients for growth hormone deficiency, one of the most important parts of this is to test the patients in the appropriate clinical context. And both the Growth Hormone Research Society and the Endocrine Society have made recommendations that the growth hormone axis should be tested when a patient has known hypothalamic pituitary disease or dysfunction. It's also appropriate to be testing patients after a history of cranial irradiation. There are lots of children who've been treated for leukemias who may have had cranial irradiation, and these patients should be tested for growth hormone deficiency. In addition, patients with a history of childhood onset growth hormone deficiency, these patients should be tested as well, and in fact need to be tested as adults after being treated for childhood onset growth hormone deficiency. Patients with traumatic brain injury and subarachnoid hemorrhage are also now recognized to be patients who may have growth hormone deficiency. So with moderate or severe traumatic brain injury or subarachnoid hemorrhage, those patients are also candidates for testing for growth hormone deficiency. As I mentioned earlier, we use a lot of dynamic testing for some of the pituitary deficiencies, and growth hormone is the best example of this. Most patients require dynamic stimulation testing, and there are some exceptions. When patients have a known genetic cause of growth hormone deficiency, then they don't require a stimulation test. Patients with childhood onset growth hormone deficiency due to any kind of irreversible structural cause, maybe it's a congenital defect or maybe their pituitary never fully developed, those patients do not need to have another stimulation test as an adult, but the patients who have childhood onset growth hormone deficiency who don't have these genetic or congenital defects, many of those patients, when retested as adults, will now have normal secretion. The other large category of patients who do not require stimulation testing are those patients, adult patients, who have multiple pituitary hormone deficiencies. And this is a good representation of that idea. This comes from a large pituitary registry of growth hormone deficient patients, the Hypopituitarism study, and what they did was they looked at patients who had failed growth hormone stimulation testing with a peak of less than 2.5 or a peak of greater than or equal to 2.5 from the stimulation tests that were employed in that study. And they looked to see how many of the patients had growth hormone deficiency and compared that to the number of other pituitary hormone deficits that the patients had. When the patients had no other pituitary deficits, it was about 41% of those patients that had growth hormone deficiency. And as we go up and include other pituitary deficits, maybe gonadotropin deficiency, thyroid deficiency, adrenal insufficiency, diabetes insipidus, we see that the number of patients with growth hormone deficiency rises to almost 100% by the time we have panhypopituitarism. When we incorporate an IGF-1 into this equation, a low IGF-1 also increased the percentage likelihood that the patient had growth hormone deficiency to also near 100% with patients with 3 or 4 pituitary deficiencies. So those patients do not require growth hormone stimulation testing to establish whether or not they have growth hormone deficiency. We know it's an almost certainty with 96 or 99% certainty that those patients do have growth hormone deficiency because of this data. The stimulation tests that are available, we have multiple tests for assessing the growth hormone axis. One of the tests that is employed is the insulin tolerance test. It is considered still to be the gold standard, but it is not commonly performed in the United States, and this is mostly because the test requires invoking hypoglycemia, and patients become symptomatic with hypoglycemia. It's a test that requires physician supervision throughout the test. And because of the laborious nature of the test and because of the unpleasant intended effects of the test, it's not commonly tested, commonly used in the United States. So therefore, alternative tests were developed. And in the past, GHRH arginine seemed to be the best candidate to replace the ITT as the gold standard test. Unfortunately, about 10 years or so now ago, GHRH was no longer manufactured in the United States and was no longer commercially available for use as a test. And so we've had to rely on glucagon because that is really the only other alternative that's applicable to adults for the testing of growth hormone axis. There are several tests that are used in children, but these tests are not appropriate for adults because they have a poor diagnostic accuracy and they're very weak in their ability to cause growth hormone secretion. And so with adults where it's important to use a much more powerful secretagogue, these tests are not usually used. So now the preferred tests are the ITT and the glucagon for the testing of growth hormone deficiency. Let's move on and talk a little bit about the treatment, and we'll go one by one and go through the hormonal axes, and we'll talk now about adrenal replacement. The preferred drug of choice for the replacement of adrenal insufficiency is hydrocortisone, and that is because of its the potency of hydrocortisone is such that we can tailor the dose a little bit more specifically using small increments of change in the dosing. It's recommended to have about 15 to 20 milligrams daily. This is much lower than the prior recommended doses of about 10 to 20 years ago when we were routinely treating patients with about 30 milligrams daily of hydrocortisone. It's recommended also to use this in divided doses, can be either twice daily or 3 times daily, and the dosing and the timing of the dose is usually tailored to avoid any symptoms of under-replacement. We try to give the patients the lowest possible dose without symptoms of adrenal insufficiency, and that's to avoid any side effects of over-replacement. The best monitoring that we have is not usually with drug levels, but with monitoring weight and symptoms of over-replacement. And so it's important to, when we're treating patients with adrenal insufficiency, always be looking at things like weight and body composition, to look at things like high blood pressure or diabetes, or osteoporosis or osteopenia, to make sure that we're not over-replacing patients that we're treating. It's also very important to give patients education regarding what to do on days that we're sick. Cortisol and the hydrocortisone that we use for replacement are very important in our response to illness. It is a stress hormone, and so it is important to double the dose of hydrocortisone when patients are having febrile illness. The other indication is usually for times when there is expected surgery, or even in times with unexpected surgery. Anytime there's a physiologic stress on the body, it's important to give the patients stress doses of steroids. So when anticipating any surgeries, a patient with adrenal insufficiency needs to make sure that their treating team is aware of the adrenal insufficiency and the need for stress dosing. When patients are sick and are unable to keep their oral medication down, if there's a lot of nausea or vomiting, then it's important for patients to know that they may need emergent intravenous therapy and may need to go to the ER or have on hand a quick pen of intramuscular injection of hydrocortisone for treatment of adrenal insufficiency acutely. For thyroid replacement, we generally use a weight-based dosing scheme. However, the dosing for patients is highly individualized, so not every patient that's the same weight will require the same dose of thyroid hormone. We usually use T4 or levothyroxine as the replacement medication, and this is because of its long half-life. The dosing adjustments that we make with thyroxine should be made after about 6 weeks, and our goal is to get the patient's level into the mid-range or slightly above for the free T4 level. It's very important, and this is another one of the sort of essential take-home messages, for patients who are hypopit, who have the central thyroid deficiency. The TSH is very commonly undetectable during the treatment of this central thyroid deficiency, and it's not helpful in monitoring these patients with pituitary disease. This is in stark contrast to other patients with hypothyroidism from a thyroid problem. And so it's important for the patients and it's important for the treating physicians to recognize that in contrast to when TSH is the best test for determining the patient's dose, in a patient with hypopituitarism, the TSH is no longer useful in determining the appropriate dose for patients with central thyroid deficiency. A very big take-home point for the patients who have central hypothyroidism. For gonadal replacement, for postmenopausal women, the treatment of these women with estrogen and progesterone is highly individualized and variable. This is because of a lot of the data that we have from the last few years about the Women's Health Initiative. There was initially a pullback on the use of estrogen for postmenopausal hormone replacement. The pendulum is now swinging back to targeting symptoms and using short-term replacement of estrogen. And so it's something that you would need to discuss with your doctor about the risks and benefits of postmenopausal hormone replacement in a patient with hypopituitarism. Premenopausal women do not fall into that category of high risk that we have established with a lot of the larger epidemiologic studies, and so it is important to treat premenopausal women with estrogen and concomitant progesterone when appropriate. And transdermal estrogen is the recommended treatment of choice because it avoids hepatic first-pass effects. Very commonly, oral contraceptives may be used, and this is still appropriate, but there may be some benefit to using the transdermal estrogen, especially when there are other hormones that are being treated, such as growth hormone or thyroid hormone, and the levels of those hormones can be affected by the use of estrogen. For men, the treatment is with testosterone, and there are a variety of methods of replacing that, all of essentially equal efficacy with transdermal gels, transdermal patches, and intramuscular injections. And there needs to be safety supervision, looking at blood counts and the prostate-specific antigen or PSA blood test with treatment of testosterone as men get older. For growth hormone replacement, growth hormone is still only available as a subcutaneous injection. It's usually started at a low dose and titrated up every 1 to 2 months. The dosing can be different depending on the gender of the patient. So men typically require less growth hormone than women, and especially in women who are either taking estrogen or have intact estrogen production. Our goals for treatment are to get the serum IGF-1 level into the 50th to 70th percentile, and to monitor patients for any over-replacement, looking at dose-related side effects such as peripheral edema, joint aches, carpal tunnel syndrome, and so again, safety measurements in addition to measuring serum IGF-1 as we move forward to treating patients with growth hormone. What are the benefits of growth hormone replacement? I have this slide in here because this may not be as clear as the benefits of replacing the adrenal axis, which is vital for all cellular activity and maintaining blood pressure. Patients can die if they're not treated for their adrenal insufficiency. Thyroid, also pretty self-evident. If you have hypothyroidism, certainly the symptoms and the repercussions of having long-standing hypothyroidism make it a requirement to treat that. But with gonadal and gonadal replacement of testosterone and estrogen, those also seem to be very self-evident in terms of the indications for replacement. But for growth hormone, sometimes this is less clear. And so the benefits of growth hormone replacement include impact on body composition with an increase in lean muscle mass, reduced central adiposity, improvement in bone density, especially in those patients who have growth hormone deficiency that began in childhood as opposed to those patients who have adult onset growth hormone deficiency. There are improvements in cardiovascular risk, including improvements in lipid profile, improvements in inflammatory markers, and other measures that we have to assess cardiovascular risk, such as an intima media thickness, which is looking at the thickness of the blood vessel walls, a method of looking at cardiovascular risk. In addition, there is an effect on quality of life, and this is highly variable, but it's certainly more pronounced if the quality of life is poor prior to initiating growth hormone therapy. So we'll go to our second case here, and we're nearing the end of the talk. This is a 62-year-old male with a history of meningioma resection and adjuvant radiation therapy. This was stereotactic conventional radiation, not gamma knife or other focus beam radiation that we have currently used today, much more commonly. And this was done in 1993. He was seen roughly about 20 years afterward for evaluation of episodic high blood pressure. And an extensive workup for the underlying causes of this episodic high blood pressure were entertained by his physicians, including looking at any hormonal causes, such as any adrenal hormone excess. But any testing that he had done thus far had been negative, looking for why the patient had episodic high blood pressure. He was very assiduous in his measurement of his blood pressure and kept this on a large chart. He measured his blood pressure 4 to 20 times per day, kept very good track of this, and found that the range was anywhere from the 110s over 60s on the low side to as high as 160 over 100s when it was high. He did suffer from some palpitations but denied any fast heart rate. He was suffering from anorexia, loss of, which was not self-imposed. He had a complete loss of appetite, and he could not exercise. He was also having problems with constipation and dry skin. Now, I should mention that in his own observations of this, he blamed his thyroid hormone replacement, which had been started about 10 years ago when he was found to have central hypothyroidism. And so he had discontinued the levothyroxine that's mentioned there in his medications, but had done this very slowly and dropped the dose over small increments over several months. And so he began having new symptoms of hypothyroidism as he dropped the dose, but he remained convinced that the levothyroxine was the thing that was causing the episodic high blood pressure. And that was the point at which he was seen by me. Now, looking at his imaging, you can see this is his meningioma that had been treated in the past with radiation. And this has been stable over several years, so there's not been any growth of the meningioma, but you can see how radiation to this mass would affect pituitary function because of the way that this mass is very close to and involves the sella and the pituitary tissue. When his hormones were tested, we checked the testosterone, which is well within the normal range. And as I mentioned, he had dropped his dose of his thyroxine down to very low levels and now had a level of thyroxine below the normal range. I performed a stimulation test on him, and the cortisol levels peaked out at 11.9. And again, we would like that level to be up above 18 after a stimulation test. So this indicates that he has adrenal insufficiency, and this has been going on for quite some time. So at that point, I started him on hydrocortisone, replacing him with 10 milligrams in the morning, 5 milligrams in the early afternoon. I reassured him that the thyroxine was not causing the symptoms, and I urged him to increase his dose so that we could get that back into the normal range. As he was followed over time, what was interesting about the episodic high blood pressure was that in general, the low blood pressures that he had been having rose in response to the hydrocortisone replacement. He no longer had the severe low blood pressures, and in fact the episodic high blood pressure got a little bit better, but what he really had was underlying hypertension and in the background of adrenal insufficiency. And so what was noted by him and the other physicians to be episodic high blood pressure was really low blood pressure is caused by adrenal insufficiency. And so everything improved once we got him on a regimen of hydrocortisone and then treated the high blood pressure with antihypertensive medication. So just an overview about radiation-induced hypopituitarism. We're going to discuss this as well as some of the other unique situations regarding hypopituitarism now. There is a dose-related relationship to the number of hormones affected by radiation, and the higher the dose, the more frequently we see anhypopituitarism. The doses that are used for the treatment of cellular pathology for both adenomas and other skull-based tumors have a high frequency of multiple pituitary deficits. And it's important to monitor the patients for long-term for hormonal insufficiency. Now, the patient that I just discussed came to me several years after having had the radiation, and that's atypical, but it's important that these patients continue to have long-term monitoring for any hormonal insufficiencies. The cumulative incidence of pituitary failure for conventional radiotherapy, which he had, and our novel uses of stereotactic radiosurgery seem to be fairly similar. There's not enough good long-term data for us to really accurately assess this, and there does seem to be some suggestion that the gamma knife and other focused beam radiation may have less of an impact on pituitary deficiencies, but currently what we see is we still see pituitary insufficiencies after use of gamma knife, and so it's still important to monitor patients going forward for any pituitary deficiencies. The other unique situation I'd like to discuss is what's called a pituitary incidentaloma. This is when a pituitary mass is found during a radiologic investigation for something else. Maybe somebody hits their head, maybe somebody's in a car accident, they have a CT scan or an MRI which demonstrates a pituitary tumor or other cellular mass. And this is a fairly common scenario. We're asked to then assess the patients for their pituitary function. And when we screen these patients, obviously we need to start with a physical exam and with a history of the patient and take a look at things that might suggest any hypersecretion of any hormones, as well as any indication of undersecretion or hyposecretion. When we see small pituitary tumors, microadenomas, these tend not to cause any kind of pituitary deficiency. Much more commonly, bigger tumors, macroadenomas, tend to cause pituitary insufficiencies. And so usually we'll evaluate these patients with assessment of the thyroid axis, we'll assess them with evaluation of the gonadal axis, and then further investigation of the other axes like growth hormone or the cortisol axis as indicated clinically. So if we assess the patients and there does not seem to be any pituitary damage, we may not need to do any growth hormone deficiency testing. If we assess the patients and there seems to not be any thyroid deficiency or gonadal deficiency, we may not need to do any cortisol testing. We need to assess those patients symptomatically, and then if symptoms suggest it, proceed with testing at that point. For traumatic brain injury, as I mentioned in the beginning of the beginning of the lecture, the hypopituitarism that results in traumatic brain injury has been noted to range anywhere from 15 to 50%. With subarachnoid hemorrhage, it's noted to be about 38 to 55%. So a phenomenon that we know does happen. However, these numbers may be also an overestimation because the testing that we have for evaluation of pituitary function is usually reserved for patients who have a high prevalence of these problems. And so the other part of this is that after traumatic brain injury, what we don't see in the clinic is a large number of patients coming to us with traumatic brain injury, and this may be that we are not recognizing it, or we may be overestimating the hypopituitarism that results after traumatic brain injury because of the deficiencies in the testing and not because of any kind of hormonal deficiency. But it is important to assess any acute loss of pituitary function. Specifically, it's very important to assess for any acute adrenal insufficiency, as well as to assess diabetes insipidus in an acute situation. Patients with traumatic brain injury should be assessed for long-term hypopituitarism, usually within 12 months of the accident. And usually basal testing of the gonadal function and thyroid function are sufficient, but we do need to rely on stimulation testing for growth hormone and the adrenal axis in these patients. So I'll conclude my talk here, and I have just some general bullet points here about some of the topics that we've discussed. I'd like to thank you for your attention. The pituitary can fail from multiple causes, as we've talked about here today, and the diagnosis of these deficiencies is rather complex, depends on multiple factors, including gender and age, as well as other aspects of the patient's health that may affect the pituitary. Treatment of these deficiencies includes replacement usually of target hormones or direct substitution of pituitary hormones in the case of growth hormone. And the assessment of hypopituitarism may be required in some commonly encountered clinical situations such as traumatic brain injury or in the setting of a pituitary incidentaloma. So again, I'd like to thank you for your attention, and I'll conclude my talk there.
That was excellent. Thank you. We do have several questions. First one, is there a clinical reason to defer testosterone and or growth hormone immediately following pituitary adenoma resection? I am 3 weeks post-op and taking hydrocortisone and levothyroxine.
Okay. So in some cases, one approach would be to anticipate any pituitary hormone recovery. And so sometimes if we can look at, especially testosterone, or in the female counterpart would be to look at recovery of menstrual periods in a premenopausal woman, or looking at gonadotropins in a postmenopausal woman. If we're anticipating that there may be pituitary hormone recovery, then immediately replacing those hormones, especially the testosterone, or giving women any estrogens, would interfere with our ability to do that. And the thyroid and the adrenal axes are a little bit more challenging to assess for any recovery. There usually is not any acute need for replacement of the gonadal steroids other than symptomatic improvement, and so that's a discussion that you need to have with the treating physician. But in many cases, it's a big asset to be able to look at levels of those hormones in the immediate postoperative time frame.
Okay, thank you. I understand that normal response to Fortressin stimulation test and a failed response to insulin tolerance test is the appropriate way to diagnose ACTH deficiency. Why are so many doctors using the Fortressin stimulation by itself to diagnose hypophysitis? How do they think they can diagnose in this fashion? Why are so few institutions using the ITT test? I think you may have discussed that. Why is isolated ACTH deficiency so difficult for even the most advanced clinicians to diagnose and treat?
Sure. So I would say that the situation of isolated ACTH deficiency is just an uncommon scenario, and so therefore it becomes more difficult to diagnose. And the use of the ITT, as I mentioned, it's kind of a difficult test to perform. It's not one that patients like going through. It's not one that that physicians like to sort of impose on the patients. And so recognizing that the ACTH stimulation test can be appropriate in most circumstances, the test is then more commonly employed. The question about why is it challenging for ACTH deficiency alone, especially in the setting of hypophysitis. Again, hypophysitis is a very rare disease. It's not commonly encountered, and so most physicians may not automatically think of that as a cause for pituitary insufficiencies. What's unique about hypophysitis as well is the predilection toward involvement of the adrenal axis over other pituitary hormones. So when I had that slide that talked about the usual and sort of customary progression from things like growth hormone, LH, FSH, thyroid to adrenal. As you can tell from the slide, the adrenal axis is usually the last one to be affected, but in hypophysitis, there tends to be a much more high percentage of involvement in the adrenal axis, and in often cases that can be the only axis that's involved. So it's a rare form and something that often can be missed for that reason.
Okay, another follow-up question to that one. I am told there are no tests for hypothalamic function. Is this true? If a patient has autoimmune hypophysitis, how could it be determined if some autoimmune hypothalamic issue were also at play?
Well, we don't have any tests that directly try to stimulate the hypothalamus in the same way that we have the pituitary ones, but we have integrated tests. So things like the ITT. The ITT, insulin tolerance test, is an integrated test of hypothalamic and pituitary function. There are other tests that are very rarely used that essentially cut off adrenal cortisol production, another integrated test of looking at adrenal function by stopping production of cortisol. These tests are, again, just not as commonly performed because of inability to get the hormones or the medications necessary to do the test, or because just of lack of familiarity with the tests that are being employed in those situations.
Okay, thank you. If you suffer from it because of use of steroids, is it the ACTH that goes away, or is it the CRH? If you have a total loss of it, is there a chance for the production to start again?
Yeah, so it is both the ACTH and the CRH that gets suppressed in patients who have an exogenous or even endogenous high level of cortisol. We see this very commonly in patients who are treated for Cushing's syndrome or Cushing's disease. In the immediate post-operative time frame, it takes a while for the glands to kind of wake back up and start secreting these hormones regularly again, and so we're required to actually replace hydrocortisone during that time frame. Is there a chance that it could recover? I always kind of hold out hope that there would be. I see no reason why there wouldn't. I know that there are some that it's difficult to accomplish that, but I always sort of keep in mind that there's potential for recovery, and I kind of work with my patients to reassess them at the appropriate times. Now, if there's a reason for repeated need for steroid treatment, say you have an underlying disease that requires an anti-inflammatory dose of any kind of steroid, then that becomes difficult to then see if there's going to be recovery, because every time there's a need for a high dose of steroids to treat that underlying disease, we then kind of have to backtrack a little bit, wean ourselves down off of the steroids, and then try to see if the glands are going to recover. So that in that situation it can be difficult, but I always try to see if there's going to be recovery.
Okay. How do you decide which patients get pituitary surgery without a definitive diagnosis?
So that's a little complicated question. If we don't know exactly what it is that we're looking at on the MRI, then that may prompt us to want to do surgery in that situation. Sometimes the appearance is typical enough that we know that it's either a cyst or it's a pituitary tumor, and we know that these things are invariably benign, and if they're not causing any kind of problems at the time, then there's really no indication for surgery at that point. I mean, that really is an individual decision that you make with your patients. When there are large tumors and there are symptoms or issues that are happening because of the size of the tumor, or if there's a hormonal indication for undergoing surgery, either from a hormonal excess standpoint, or if there's pressure on the normal pituitary causing hypopituitarism, then that pushes you towards surgery. But In an unknown situation, most of the time it comes back to what we anticipate to be sort of the usual appearance of things on an MRI.
Okay, I had surgery for a pituitary prolactinoma. Prolactin was 3,500 at the time of surgery. The majority of the pituitary was removed. I am taking HGH, Cortef, testosterone, and thyroid medication. For 3 years, I was on Levoxel. I've been switched over to West Thyroid Natural medication. I feel a lot better on this because it has T3 and T4 in it. Have you ever used this in your practice? Is there anything else I should be on to make my quality of life better?
Okay. Well, it sounds like most of the pituitary hormones are replaced in that situation. I mentioned in the talk that I prefer using purely levothyroxine and not combined medications, and the reason for that is because of our ability to use or inability to use the TSH as the marker for adequate replacement. The hormone levels of T3 and T4 that are included in natural preparations or when used in combination with other synthetic preparations of T3 are difficult to determine, and it comes back to the rate of metabolism of these hormones. T3 is metabolized much faster than T4, and it comes back to the levels of each of these hormones that are in the preparations that are being taken. And very commonly what we'll see in patients without pituitary disease who are using these natural preparations is a lower level of T4 and a higher level of T3, but that all depends on when the tests are done compared to when you took the medication, because the T3 metabolism can be quite rapid. So the reason that I avoid using them is because I have a difficult time assessing whether or not somebody is over-replaced because of the lack of ability of using TSH. I certainly recognize that when you look at studies and looking at combined medication versus T4 only preparations, there seems to be a patient preference for the combined medications. There seems to be some improvements there. The difficulty is in the patients with pituitary disease and the difficulty in assessing the adequacy of the dosing.
Okay, thank you. How tall, bone age, recovery of GH IGF-1, acceptable peak bone mass achieved?
I'm sorry, can you repeat that?
Yeah, that looks like it was a question to maybe a specific slide. How tall, bone age, recovery of GH IGF-1, acceptable peak bone mass achieved?
Okay. The question may be referring to goals of therapy, and with the question of things like bone age and peak bone mass and things, those are generally speaking, and final height, those are generally speaking the outcomes that pediatricians will use for the treatment of stature and the appropriateness of growth hormone. So in children who have where their bone age is advanced so that there's no more potential for growth, then we know that final height is usually achieved with growth hormone therapy in that situation. Those kinds of goals then recede, and we then think about growth hormone more in terms of its metabolic effects. And so there's kind of a change in the goals of therapy with patients with growth hormone.
Okay, thank you. Do you draw timed ACTH with cortisol since ACTH also has a diurnal rhythm? How can an ACTH test diagnose secondary AI at any time since with adrenal atrophy, little or no cortisol will be secreted, so no response to ACTH should be expected? If the ACTH level is low, then both the pituitary and adrenal would be knocked out. If there is no adrenal atrophy, then the proper test would be using a CRF test if that hypothalamic factor is still available.
Yeah, so CRH, also kind of difficult to come by. We use it in different scenarios, and has not really been widely accepted as a test of central adrenal insufficiency or assessing the HPA axis. I'm not exactly sure why that is, but it just hasn't been as widely accepted as others. There just may not be enough data in the literature to support it. There are several tests using, or several papers using it, and so it may become something that's more widely accepted in the future. The question about the ACTH levels. The ACTH is, again, sort of, it's a pulsatile hormone. And in contrast to what we see in other sort of hormonal patterns, the pulses of ACTH and cortisol do not always align so that in kind of a seesaw pattern the cortisol is low and the ACTH is high, unless there's a true deficiency in either situation. So if there is a deficiency in cortisol, then we check the ACTH to determine whether or not somebody has a primary or a secondary adrenal insufficiency. In cases where we are dealing with a patient with a known pituitary issue, the assumption is that this is going to be a central insufficiency, and so then the ACTH level itself becomes much less relevant to our making the diagnosis. But your point is well taken that the ACTH level should be helpful, but it really depends on knowing the integrity of the HPA axis. If we know that the cortisol is low, it is helpful. If we don't know that the cortisol axis is affected, then it's not as helpful because of the pulsatile secretion of the hormone.
Okay, thank you. How do we make more good hormones than bad, or more bad hormones than good ones? It seems like that for me anyway. How can we raise our metabolism if we don't make enough growth hormone? I used to be on GH, then got taken off because I had stage 4 melanoma 11 years ago.
Well, I don't know the answer to the first question. How do we get our bodies to make more good hormones than bad? I can only kind of give general health recommendations of just doing things that we all know and accept to be good things for our bodies. But in a patient with hypopituitarism, that becomes exceedingly difficult. So I don't know the answer to the first question. In terms of, are there things that we can do to help our metabolism? Again, this becomes something that becomes more controlled by the hormones that we take and the manipulation of the levels of those hormones. We want to always be safe in the replacement of any of these medications, and so especially in light of a history of a malignancy, you'd want to be very cautious with that. The real contraindication to growth hormone is an active malignancy, something that is happening currently, and if there's enough time away from the diagnosis and treatment has been sort of deemed successful, that's a situation where, in discussion with the patient's oncologist and with the patient accepting any kind of unforeseen risks, but that's a situation that may be appropriate to re-implement growth hormone. It would be something that you need to be very cautious about, and really that's an individual decision and not something that would be widely recommended.
Okay. I have a pituitary-cytoma, which is a benign mass on the pituitary stalk. Do you approach masses like these any differently?
Well, pituitary-cytomas are, generally speaking, very slow growing, and the morbidity of treatment of them is a little higher in that because of the location of the pituitary-cytoma at the base of the hypothalamus, or usually kind of involving the pituitary stalk, in many cases will result in panhypopituitarism. And so because of the slow-growing nature of pituitary-cytomas, sometimes observation is chosen, especially if there's normal pituitary function. So the approach is slightly different. It comes back to the basic elements of assessment of risk and benefit, and looking to see what the best choice is at the time.
Okay, are there any advantages for using prednisone instead of hydrocortisone for hormone replacement?
Yeah, so prednisone, I recommend hydrocortisone because of its short-acting nature, but then again, if patients don't like taking a medication 2 or 3 times a day, then prednisone, which is longer acting, can give patients the longer coverage of the steroid without needing to take a second or third dose of the hydrocortisone. The drawbacks to that are that I believe that a longer acting hormone predisposes to some of the side effects of the hormone, and the dosing is much more challenging because we can't, even with 1 milligram increments of prednisone, we can't really make the same kind of dosage adjustments that we can with hydrocortisone, or at least it becomes a little bit more clumsy, I think.
Okay, we still have a lot more questions, but we're going to have to wrap it up soon. So I'm going to do a couple more, and then the rest we'll have to possibly try to answer by email. I was tested for hypopituitarism 1 year after a TBI and came back with normal results. I'm still dealing with the same troubling symptoms, hair loss, low libido, regular to no periods. 5 years later, would further testing be merited?
It's unlikely, because we do know that there are some patients with traumatic brain injury who get effects later on after the traumatic brain injury, but that is fairly rare. Usually if the assessment has taken place within the first 12 months and away from the actual event, like, waiting at least 3 to 6 months after the event and then an assessment at that point, it's unlikely that there may be changes. The recommendations most recently that I've seen go out to an assessment within 5 years, but that would be sort of a first assessment. So it seems unlikely to me that things would change. What's more likely, and I alluded to this in the talk, is that the imprecision of some of the tests that we have, the variability that we have in response to a growth hormone stimulation test, for example, may contribute to some of the misdiagnoses that we have seen in the past in several situations. So, so the testing becomes more challenging. It's unclear whether or not there's going to be any difference once you've tested negative that far out from the injury.
Okay, thank you. Within 9 months of Wernicke's encephalopathy, symptoms led to testing of hormones and revealed hypogonadism and zero cortisol. Have you encountered, looks like SAI caused by WE before?
Adrenal insufficiency. So not from Wernicke's encephalopathy, no. I think there is a relationship there between with the hypogonadism, but it maybe because of any kind of cause of the Wernicke's encephalopathy. But I have not encountered adrenal insufficiency because of that. Again, assessment of these hormones is also kind of tricky because we rely on a lot of testing in the blood that hinges on our protein status. So things like all the binding proteins that affect testosterone, like sex hormone binding globulin or cortisol binding globulin, if those things are affected, then often the testing that we have for the hormones can be affected as well.
Okay, thank you. One last question. If you stopped having steroids, will you immediately suffer from loss of production, or can you feel well for a month and then suddenly be sick?
Well, so if you're referring to steroids like glucocorticoids, I've found that patients, especially if the insult is more of a gradual phenomenon rather than an acute injury, that the symptoms may not be readily apparent initially, may happen over time. Similarly with testosterone, and maybe because some of these hormonal levels may not drop off precipitously, they may just sort of gradually decline. So the symptoms often are not immediately apparent after an event.
Okay, thank you. We do have some more questions, but as I said, we'll try to get those answered by email. We are out of time.
Okay.
Thank you, Dr. Carmichael, for this fascinating and valuable information. This concludes today's webinar presentation. We appreciate you taking the time to join us. If we did not answer your questions, we'll be answering them by email. If you missed any part of this webinar or you would like to share it with family members or friends, it'll be available on our website after it is edited. The PNA wishes to thank you for participating. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us, and enjoy the rest of your day. And Dr. Carmichael, thank you so much. We're getting a bunch of thank you messages from the viewers as well. Everybody have a wonderful day. And
the invitation. Thank you.
Thank you.